now shifting to gynecological malignancies. It's my pleasure to be with you in Ain Shams University Oncology Conference. First talk will be updates in systemic treatment of ovarian cancer. Professor Frederick Marmay will present the presentation. He is a professor of gynecology for medical faculty of medicine of Heidelberg in Germany. Professor Marmay is currently head of the translational gynecologic oncology section at the National Center for Tumor Diseases in Heidelberg. He's an elected member of the German Breast Group, the executive board of the German Society of Gynecological Oncology. Welcome, dear professor.
Hello, everybody. Can you hear me?
Yes. Now I would like to present Professor Frederick Marmay. He's a professor of gynecology for the medical faculty of Heidelberg University in Germany. Professor Marmay is currently head of the translational gynecologic oncology section at the National Center of Tumor Diseases in Heidelberg. He's an elected member of the German Breast Group, the executive board of the German Society of Gynecological Oncology. Professor Marmay.
Hello, everybody, dear chairs. I hope you can hear me loud and clear. It's a great honor to be speaking to you at this prestigious meeting, and I deeply regret I can't be with you in Cairo. I really would have preferred, and I also had some difficulties, technical difficulties, dialing in, but I hope everything's fine now. Now, the topic is ovarian cancer, and I want to give a short overview of the state of the art in the first-line treatment, and also some important news that we have learned over the year, this year. So, let's first take it one step back, and I think we need to remind ourselves, and this is actually a Kaplan-Meier curve from a study which was presented and published not too long ago. It's the control arm of the SOLO-1 study that I'm going to refer and demonstrate to you in just a couple of minutes. And we see that despite all efforts, results are quite poor, and that many patients even relapse within the first 6 months. And if we think about PARP inhibitors, for example, in first line and second line, then platinum sensitivity is a big issue, and many of these patients relapsing as early as that will not be eligible for PARP inhibitor maintenance therapy later on. And then we also observe a plateau of this curve at around 3 years to 4 years at 20% of the patients that do not recur. And so there is an opportunity and potential for cure, and it's the goal to increase that really. And the only situation where we can achieve possible cure is the first line setting. So we should give the best treatment that we have in first line. And let me just take a look back at the progress that has been made during in first line therapy of ovarian cancer. And you see that, in fact, in terms of chemotherapy, there hasn't been any change for more than 20 years in terms of efficacy. The only thing that happened was the exchange of cisplatin for carboplatin, and that's basically based on the toxicity profiles, really. There was a small step, as I would call it, in the year 2011, and that was the introduction of bevacizumab in first-line treatment in addition to chemotherapy, and then followed on as a maintenance therapy, and that improved PFS versus chemotherapy alone. But the true paradigm shift was really the introduction of PARP inhibitors in the first-line treatment as maintenance therapy. The first study was the SOLO-1 study, but that exclusively recruited BRCA mutant patients. And then the next two important trials, the PRIMA and POLA-1 trial, addressed the question of the efficacy of PARP inhibitors beyond BRCA mutation carriers, and we'll have a look at that. I just want to show you some data of the evolving quality of care in Germany. And you see on the left-hand side, I think this is important because that's been achieved by means of education and educational programs, and that's that surgical outcomes have significantly improved from 2004 to 2016. You see the green bars are the patients that have been operated without any macroscopic residuals, and that's the strongest prognostic factor in first line, really. On the left-hand side, you see the changes in systemic therapies. So even at 2004, the majority of patients, over 80%, received carboplatin and paclitaxel as the standard of care. But what happened during the time is that the introduction of bevacizumab can be observed, and by now, 2/3 of the patients receive bevacizumab as standard of care in first-line treatment. Obviously, there are some patients that have contraindications, and some patients that might not even get any therapy at all. What is most interesting, in parallel, we see improvements in outcomes. So on the left-hand side, for all patients, and that's from period to period, there is a stepwise improvement. And it's not quite clear, because that's the time prior to PARP inhibitor therapy. Obviously, there was the introduction of bevacizumab between 2008 and 2006, but many of these differences in the curves occur quite early, so during the first year of therapy. So maybe there's other factors like the perioperative management that play a role, as well as maybe also diagnostics. But this also can be observed in patients that have been operated without any residual disease. So there must be more to it than just the improved operating outcomes that we've observed in that study. As mentioned, first-line bevacizumab has been around for about 10 years. So maintenance therapy is not a new concept, and there's basically two first-line studies, the GG218 and the ICON-7 study. And both have shown a modest improvement in PFS, really, but in the overall population, no improvement in overall survival. That was only seen or suggested in subgroups selected for high risk. These subgroups have been defined differently in the two trials, and in fact, if you take the definition from the one trial to the other trial, you don't see that overall survival benefit anymore. So there is a suggestion, but it's clearly not proven. This is one of the reasons why people started to think maybe it's the duration of bevacizumab in first line that is too short. And this was actually addressed now this year at ASCO by the presentation of Jacobus Pfister of the ARGO-OVA17 study. And the reason why this hypothesis came up can be seen here. At the time when in the two trials, GOG218 and ICON-7, the therapy was stopped, the difference between the two arms were the greatest, and the effect that vanished after stopping bevacizumab. So it was quite clear and convincing that it would be worthwhile to test if a longer treatment with bevacizumab was beneficial. So this is a trial, a phase 3 trial, randomized, which basically included patients with advanced stage ovarian cancer and randomized them to standard of care chemotherapy plus either 15 months of bevacizumab or, in the experimental arm, 30 months of bevacizumab. This has been presented at ASCO this year, as I mentioned, and it came to a very clear result. So PFS was not improved by a longer duration of bevacizumab. Neither was OS. I didn't show you here, but so the best duration of bevacizumab remains 15 months. There wasn't much more toxicity based on the longer treatment, but still there was no added effects. So we can summarize that. Bevacizumab is a standard, maybe not the standard, but a standard of care in the first-line treatment of ovarian cancer. The duration of treatment has defined now by the ARGO Boost study, and there is only a suggested benefit in OS in high-risk group. But, and this is, I think, also important, mainly those patients with high risk of recurrence, and maybe this is also important for those patients benefiting less from PARP inhibitors, but we'll see that in just a second. So far, there's also no data to support an interaction between bevacizumab and HRD or BRCA status. I think this is also important because I think bevacizumab is a very, very good option for patients with HRD negative tumors. So let's look at the introduction of PARP inhibitors in first line. Soleimani was the first study that was presented, and it included patients with newly diagnosed stage 3 and 4 high-grade epithelial ovarian cancers. All patients, and this is important, all patients had to have a BRCA mutation, and they had to have a response to platinum-based therapy. And these patients who were eligible were then randomized 2-to-1 to receive either olaparib for 2 years or placebo for 2 years. There was a smaller fraction that continued after the 2 years because they still had some measurable disease and benefited from treatment. The primary endpoint was investigator-assessed PFS, and that's shown on the next slide. And this is really a remarkable Kaplan-Meier curve with a difference of 27% at 5 years between the treatment arms in terms of progression-free survival. And if you look at the medians, the olaparib maintenance has improved PFS, median PFS, by more than 3.5 years. And also important, there seems to be a plateau at the end of the curve, so maybe we're seeing some long-term responders, and that gives you hope for cure in more patients at that stage and in that setting. Looking at clinically defined higher and lower risk groups by surgical outcome, timing of surgery, there's no difference really. So those patients with a lower risk benefit as much as those with a higher risk base of residual tumors or FIGO stage 4 disease. So this, this has been quite straightforward, that PARP inhibitors actually work in BRCA mutant patients. And I just brought you this slide from the initial preclinical data where it really demonstrates that BRCA is a very, very good predictor for benefit of PARP inhibitors. And they really need to have deleted both alleles to achieve this efficacy. But BRCA1 and 2 are just two of the components of a large and complex network which is working together to achieve homologous recombination repair, which again is the very accurate means of repairing double-strand breaks, which is needed to repair the DNA that's been damaged by the administration of a PARP inhibitor. So there's more to it than just BRCA1 and 2, and from early data we know that even in BRCA wild-type patients, there is a large proportion that respond to treatment with with PARP inhibitors, here shown in this trial. So all the light blue patients are BRCA wild-type patients that show a response rate of 50%. But how could we identify these patients? That's an important question. And for that, I think it's important to bear in mind that homologous recombination deficiency is a phenotype with many causes. So it could be mutations in BRCA, somatic and germline. It could be mutations in other genes that are related to HRR, though that there is no consensus about what these important genes really are. There could also be change expression by promoter hypermethylation, for example in BRCA1 or RAD51C, and there's other causes which are still unknown. And obviously it's very difficult to test for each of the single genes and all the different mechanisms of inactivation, and it's basically impossible to test for the unknown anyway. So this is why researchers came up with the idea not to test for the reason for deficiency in homologous recombination repair, but rather for the effects. So this is what is called HRD scarring or genomic scar assays. They're really looking for the scars on the genome that are specifically left behind by a non-functioning homologous recombination repair. And this is a good example of this depicts the strategy. Instead of looking why this car has crashed, so was it brake failure, a distracted driver, or a self-driving vehicle, it's rather the interest is that the effect was there is a car crash. And there are some features that are given above, which are characteristic for HRD, and they're called LOH, telomeric imbalances, and large-scale state transitions. And they can be actually measured, and there are some commercial tests which provide these information on top of a somatic BRCA status. So this is the example of the Mermaid choice assay, which was used in the first-line studies, but there's always also the Foundation Medicine 1 LOH assay, and that was, for example, validated in Ariel 3. Now let's take a look at the first-line trials. We've already looked at the SOLO-1 trial, and there's important differences between these three trials. So SOLO-1 has no selection for high risk of relapse, so complete resection, no macroscopic residual was allowed. And that's a situation where it is more difficult to really observe a response to platinum, which is a very good predictor of PARP inhibitor benefit, so you're less certain that the patient responds if there is no residual. But SOLO-1 selected for the best biological predictor, which is the BRCA mutation, at least as we know so far today. Now, if you look at the next two trials, the PRIMA trial investigating niraparib as maintenance therapy, we can see that there was a strong selection for high risk of relapse, and this is paralleled by a strong ability to evaluate the response to platinum, because you have residual disease, or you have FIGO4, or you give neoadjuvant chemotherapy. So all situations where you can directly assess response to platinum. In addition, patients have to have a drop of CA125 of about 90% or more. Now, Paola, in terms of treatment and design, was different. It investigated the combination of the PARP inhibitor bevacizumab and did not select for high risk of relapse. So many of the patients had no residual disease after primary debulking surgery. Again, difficult to assess platinum response. And in addition, patients all received bevacizumab even during chemotherapy, and this also dilutes the effects that you observe when you observe effects. So because partly some of the responses will be due to the bevacizumab. So distinct differences between these trials, which are important to bear in mind. Let's look at the data from PRIMA first. So that's a randomized trial with a selection of high risk of relapse and potential to observe response to platinum. Patients were, after chemotherapy, randomized 2-to-1 to either niraparib for up to 3 years or progression or placebo. And the primary endpoint was PFS, first in the HRD positive tumors and then in the overall population, and that's shown here. So there is a clinically really meaningful difference in both subgroups, especially in the HRD positive group with almost 1 year of prolongation of PFS. But even more interesting is to dissect these subgroups even further, and you can see that there is a huge difference in the HRD positive, and they're consisting of BRCA mutant and those BRCA wild type with a positive HRD test. So there again, a difference in PFS in the median of almost 12 months. But there's a small difference also in the HRD negative subgroup, and that accounts for 34% of the patients in this group. The difference in median is only 2.7 months. The hazard ratio 0.6. So you could argue how clinically meaningful really is that. So basically, even based on this trial, the HRD test does really predict at least the magnitude of benefit from PARP inhibitors. It's even more convincing if you look at the PAOLA-1 studies. First, look at the design. So it's olaparib versus placebo combined with bevacizumab, and the PARP inhibitor was given for 2 years. All comers were recruited independent of BRCA mutation status, and many patients did not have residual disease after surgery. And the primary endpoint is shown here. It's PFS in the overall population, and you can also see that the hazard ratio is 0.59, which is a strong signal, but doing the same as before for PRIMA. Let's also look for the biomarker-defined subgroup. And again, here you see the largest effects for the BRCA mutant and HRD positive tumors, and only or no effect at all for HRD negative tumors. Interestingly, and I'll show you this because I think this is the best data that we've seen so far, especially in the lower risk subgroups, so patients with no residual disease after surgery, after primary debulking surgery, the hazard ratio is 0.15, and at 2 years, 90% of the patients had not progressed. So this is really reassuring, and hopes are risen that some of these patients will be cured in the end. Now, we don't know what the additional effect of bevacizumab is, and there's only one very indirect supporting evidence, and this is a study presented by Ignaz Vergote, comparing the BRCA mutant population from Solo 1 to Paola 1, and what you can see here is a similar hazard ratio like in GOG to 18. But there's additional effects of bevacizumab, and this is you increase response rate to chemotherapy. And that might be especially important in patients with HRD negative tumors because they're less likely to really respond well to platinum-based chemotherapy. So to come back to the thoughts of the combination of bevacizumab with PARP inhibitors, I think, you know, these patients in Paola, many of them would not have entered the PRIMA trial because, or some of them, because they would not have responded clearly to chemotherapy. And so this is a very important option for them because bevacizumab will increase response rates. And that's particularly important for HRD negative patients, but when we test, we find out this only during the course of the chemotherapy. So I want to summarize the efficacy of these different PARP inhibitors and combinations in the different subgroups. Keep it very simple and focus first on the BRCA mutant population, which is about 30% of the patients. And you can clearly state that for these patients, all options, except just bevacizumab on its own, are valid options. So olaparib for the mutation carriers, PRIMA, niraparib for the HRD, for the BRCA mutation carriers, as well as bevacizumab in combination with olaparib as per Paola data. If you focus at the HRD positive, but BRCA wild-type population, it's very similar. So both options, Paola and PRIMA, are valid options and are very suitable to treat patients. So either given niraparib alone or the combination of olaparib and bevacizumab. The last group, again, is very interesting, and that constitutes about 50% of the remaining patients, the HRD negative group. And if you look at that, Paola, I think it's quite clear that it's not an option, but both GOG to 18, so bevacizumab, already given to chemotherapy, or PRIMA, but that starts at a later stage, are valid options with very similar hazard ratios. Personally, I think so. This summarizes the treatment options that we have and that are approved, at least in Europe. What we do is the first step is to think who is a candidate for bevacizumab. Then we start treatment, we observe the response, and we perform testing for germline BRCA and HRD. And then when they're HRD positive or BRCA positive, we'll add in olaparib or a PARP inhibitor to bevacizumab. If they're negative, we'll continue bevacizumab. And those patients that we think are not candidates because of contraindications for bevacizumab, we give chemo without, and then add niraparib as maintenance therapy if they have responded. Now, I very, very briefly want to give a short update on the ESMO, because I think this is important, the data that we've seen. Now, most patients receive PARP inhibitors either in first line or in second line. So the patient population that really causes problems and where we don't have any clue how to treat them are the PARP pre-treated patients. And the OREO trial that has been presented by Eric Pujol-Lorraine at ESMO this year actually was addressing this question as the first randomized phase 3 trial. This is the study schedule. There's 3 important points. First of all, patients had to be pre-treated with PARP inhibitor, and they had to be so long on the PARP inhibitor that you could assume that they had actually derived benefit from their first PARP inhibitor treatment. So that was a prerequisite to enter the trial. But the second and most important step was they had to respond to platinum-based chemotherapy again. So as the best predictor in that situation, responds to platinum. And this was the prerequisite prior to randomizations. And patients were recruited into two separate cohorts, the BRCA mutant and the BRCA wild-type cohort, and then randomized to receive either olaparib for as long as disease progression or intolerable toxicities, or the corresponding placebo, and the primary endpoint is investigator-assessed PFS. This gives you a short overview about the timelines, and I think it is important that the trial started even before we knew the data from Solo 1 and PRIMA and Paola. and it only closed shortly after the pre-Mermaid data. So within the trial, very few patients had their PARP inhibitor therapy during first-line treatment. And if you look at the patient disposition or characteristics, it's also clear most patients were heavily pre-treated. So over half the patients had 4 or more lines of chemotherapy and 3 or more lines of platinum-based chemotherapy. In the BRCA mutant cohort, most patients received olaparib as the prior PARP inhibitor. So these patients received the same PARP inhibitor after the same during their prior lines of therapy. In the non-BRCA mutant cohort, there's some mix, but it's important because it does also answer the question, do we need to change or switch the class or the drug if we want to re-challenge? And these are the data for the BRCA mutant cohort. If you look at the medians, it doesn't seem to be such a big difference, but this is because the Kaplan-Meier curves actually dropped down very steeply at the very beginning in the first 3 months. But then they start to separate, and I think what is quite remarkable is that we have some long-term responders. So at 12 months, even still 90% of the patients receiving olaparib were still on treatment and had not progressed, whereas none in the placebo arm. So this is a biomarker-selected BRCA mutant cohort, but the same was observed really in the BRCA wild-type cohort. So same hazard ratio 0.43, which is really good, and also there are long-term responders, one of them even almost up to 3 years. So this clearly is a treatment option that we have gained by that. And, the last point, talking about biomarkers, is that the BRCA negative subgroup has been dissected into HRD positive and HRD negative. And if you look at that, you can see it doesn't matter. So the same effects were seen for HRD positive and HRD negative patients. So what really is the prerequisite to do this strategy is that you observe response to platinum and also to have a longer duration of PARP inhibitors on their prior therapies. And that's been very well defined in the trial and has led to these results. So basically, many of my colleagues in Germany at least have done that without knowing what they were doing. Now we have the data, so this is the first story about PARP after PARP, which is positive. I think I've used up all the time for my talk, and I want to thank you for your kind attention, and if there are any questions that I might answer, I'm happy to do so. Thank you.
Thank you so much, Professor Marmay. Any questions from the audience? Okay. There is no questions? There is one question here, Professor Namet. Question here, please.
Hello, thank you, Dr. Frederick, for your nice presentation. My question regarding the toxicity of olaparib. It's oral medication. Sometimes if a patient complains of epigastric pain, cannot tolerate taking 2 tablets morning and 2 tablets evening, how we can make modifications of this toxicity? This first question. Second question is, what about if the patient relapse after 7 months of the first line? Do you hear me or?
So for the first part of the question, I think taking the tablets with a small meal can be quite helpful.
Taking
PARP
what?
inhibitors could be also switched.
Sorry.
At least in that situation. So sometimes this is something what we do, but taking them together with a small meal is helpful. And you know, if you have a PARP inhibitor that's only given once a day, like niraparib, that might be preferential if you could take the dose at the evening. Maybe that's helpful. But if you look at the trial data, the rates of even lower grade nausea, vomiting, and GI toxicities are extremely similar for the drugs, irrespective of how many times a day you need to give them. As to the second question, obviously, and I didn't address this topic, we have moved away from these very, very strict rule of 6 months in terms of platinum sensitivity or platinum resistance, because there's too many factors that actually play a role. One of the factors, and that's a very strong factor, is was there macroscopic residual disease or not? Because for a patient with no residual disease after surgery and upper debulking, 7 months is very little, really. But for someone with residual disease who did not receive any maintenance therapy, that's maybe even surprisingly long. So it depends on these factors, and I think the question that needs to be addressed, first of all, what was the maintenance therapy like? I would assume that this patient had received a PARP inhibitor. Based on the timelines, she would still qualify for platinum-based therapy, and then obviously it's very important to see how they responded. One of the important factors is, first step is always to think about surgery, even in recurrent disease. So if she's a candidate, that would be the first step. And then what alternatives do you have? If you have a clinical trial, that's always a good bet. There are many clinical trials with immunotherapies, although we don't have any good signals from immunotherapy in ovarian cancer so far. But today, 6 months in a patient without a BRCA mutation, I mean, obviously this is also a factor that plays a role in determining the potential role of platinum re-exposure, and then going hand in hand with that, also a PARP inhibitor re-exposure. So for someone with residual disease at surgery without a BRCA mutation, 7 months is even more like the experimental arm in PRIMA than the control arm. So for BRCA negatives, 7 months of PARP inhibitor would have been enough to include them. If that was no, it wouldn't be in first line, really, you had to have 12. So it would not fulfill the OREO criteria, because this patient should have been on 12 months of prior PARP. But observing the platinum response will probably help you to decide if you would try or not. So short question, very complicated answer, because there's so many influential factors in making these decisions.
Okay,
Thank you.
Any other questions? Dr. Ahmed?
Good evening, sir. I'm asking about we know that the most common and distressing side effect for PIVA is hypertension, and I'm asking how do you deal with the patients, especially who develop renal impairment or hypertensive complication, especially when you combine it with olaparib?
So in fact, the combination with olaparib has not increased the rates of at least grade 3 and 4 hypertension. It was actually a bit lower than that. Maybe that's because there was a pre-selection of patients tolerating bevacizumab better, but I don't know. There's no real good explanation. So I mean, this does play into the matter of whom you consider a candidate for bevacizumab. So if you have someone with a poorly controlled hypertension, that might not be a good candidate. And if it occurs, you just need to try to figure out the control. But the combination doesn't seem to make hypertension worse. If you're thinking about alternatives, so niraparib itself causes hypertension grade 3 and 4 in 6 to 8% of the patients, depending on which trial you look at. So, in fact, hypertension is one of the pre-existing conditions that you really need to look out for. It would not prevent me to combine olaparib and bevacizumab. It's more a question if you can continue with a good antihypertensive medication, or if you have to stop bevacizumab if you get renal impairment or proteinuria. So I think that this is more the question, and if what you do then. Yeah.
Another question, you know that the pelvic surgeries or pelvic operations usually combined with high incidence or high risk to develop DVT, especially in obese females, which are the classic criteria for the female with who can develop ovarian cancer. So if you have a patient with this criteria, hypertension, obese, high pelvic disease, with relapsed disease or second surgery, would you recommend to do BEVA, to give the patient BEVA, or you can from the start avoid it and give her another protocol?
So I'm not quite sure if I completely understood the question, but I think I got the meaning of that. During first surgery, we continue anticoagulation after hospital dismission for at least 60 days. So that's one of the points. And if I've got a patient where I'm really concerned that she would develop a DVT, I would probably continue prophylactic anticoagulation. So looking at these factors, there's been some data at ASCO this year on that topic. And then you start chemotherapy and you have responses usually that are quite large, and so if the situation might change, if I would still be scared and I would consider that anticoagulation is not enough to prevent a thrombosis, I would stay away from bevacizumab. But actually, I can't remember a case where I thought she might develop a thrombosis. It's rather a matter of starting BEV later than earlier and continuing some anticoagulation, some prophylactic anticoagulation.
Good evening, Professor Frederick. My question for you is, according to the recent guidelines, niraparib is indicated for patients with BRCA wild-type HRD negative patients. Do you think that the results of those subtypes of patients from the PRIMA trial, the few months progression-free survival benefits outweighs the financial toxicity and the toxicity of the drug? I think niraparib is not a friendly drug like olaparib, especially thrombocytopenia and other complications. So do you think in those subset of patients we have seen a progression-free survival around 5 months or even more? So does this progression-free survival benefit outweighs the financial toxicity and the toxicity of the drug? Do you believe in that? Or are you convinced?
Very, very good question. And to give a brief answer, I really doubt it. Okay, so rather no than yes. And I think there is an alternative. I as a patient, I wouldn't be convinced by the Kaplan-Meier curves. And I think if the other Kaplan-Meier curves for the BRCA mutant patients wouldn't have been presented alongside, this would not have entered clinical practice. It's a way not to test, which I think is bad, because you want to know if the patient is HRD positive or not, because you also for the HRD negative, the motivation to stay on a PARP inhibitor if you tolerate it poorly is a lot less, and you would not advise maybe so strongly to keep on trying as you might do if you know the patient is HRD positive. So, and there is a great alternative, and this is bevacizumab if there is no contraindications. I don't know about the prices of Bev in Egypt, but it's cheaper. And if you have asked patients, other than it being IV rather than oral medication, it's usually very well tolerated. So I think for the HRD negative patients, all these treatments, bevacizumab or PARP inhibition with niraparib is a good choice. And I personally, because we decide upon the addition of Bev prior to the knowledge about the biomarker status, obviously this results in those patients being treated with Bev and ending up being HRD negative, they get bevacizumab. So this would be sort of the standard, only in patients where you can't give Bev because of prior complications, uncontrolled hypertension or something like that, then I would consider something else.
Thank you. Totally agree with you. Thank you, Professor Frederick.
Any other?
Okay, until this is managed, we will shift to next speaker, Dr. Basil Rif'i, to talk about conservative approach in cervical cancer. Please, Dr. Basil. Dr. Basil is not here.
فين المحاضرة بقى؟ مين حاطط المحاضرة؟ باسل لا شوف حد من الاي تي بس. Yes.
Forward, backward with a pointer.
Okay, pointer or forward. So, good afternoon, everyone. Sorry, I didn't know that the first lecture would be skipped. And it's always my pleasure to be here in the great Ain Shams Oncology Conference. Being a surgical oncologist in between, I don't feel so strange because I have been dealing with oncologists for more than a decade right now. So for Ain Shams conference, of course I don't have conflict of interest, I am a surgeon. However, I have some good memories here because I have received £5,000 from you. Like in the second Ain Shams Oncology Conference, I got the award of the best young oncologist researcher, and they were very astonished that there are some surgeons who do research really. I was just a junior lecturer then, and it was in 2015, yes, I was just promoted as lecturer, and so I am owed for you by £5,000. If you want them, I can give you back right now. So cervical cancer is common among women worldwide, and most cases occur in developing countries. And in developed countries, we all know that there is a decrease in cervical cancer incidence and mortality rates, which are related to availability of screening HPV vaccination programs. From 2020 to 2013, the FIGO, the ESGO, the IGCS, the whole are uniting, and they say that it will be the decade of eliminating cervical cancer. All are in a task force to eliminate cervical cancer worldwide from 2020 to 2030, or decrease as much as we can. But what's the situation in Egypt right now regarding cervical cancer? Do we have a problem? Do we have some problems? Is everything okay? Let's start by screening. Of course, we all agree that we don't have established a screening program, and we don't have a registry to know the magnitude of the problem. And for vaccination, there is no widespread vaccination. There is no awareness of vaccination. I'm so sorry that when I spoke about vaccination, even doctors, even gynecologists, they don't know that there is a vaccine for HPV. They don't know that. What about the public? The public don't know anything about the vaccine. When we started speaking about the vaccine, I think 1 year ago, very, very many people were astonished that there is a vaccine for HPV and that you can prevent near total some sort of cancers. But again, you have a problem dealing with the gynecologists per se, and some doctors who say this is a disease of sexually active females who have multiple partners, who have many sexual relationships, and we are conservative countries, so we don't have cervical cancer in the region in Egypt. It's like boring. So from the Globocan, we have around 1,694 cases per year, and we have mortality like 744. So more than 70% of cases we have mortality. This is a very, very alarming sign. And it is not far away from uterine cancer, it is not far away from ovarian. So if we say ovarian are 2,000 cases, we are speaking cervix 1,319 cases, and we all know these numbers are not accurate, but they give some indicators. And for example, the colon cancer is 3,000 cases, but when you have 744 mortality out of 1,300, this is a very alarming number that we can prevent those mortalities. For the radiology, we again all agree that there is faculty of specialized radiologists in gynecological oncology. There is no people who believe in the specialty, the people who can do a good transvaginal ultrasound, and we have many cases with misinterpretation of MRI. When you go to do and examine, you find completely different things rather than what you see in the TVS report or in the MRI. For the gynecologists, they are not well trained for cervical cancer surgeries, And even what's more, they are not interested, most of them, how to leave obstetrics and doing the IVF and all those easy money-gaining issues. But we are not going to deal with gynecology with all its others. And they believe, again, that is not a common disease in Egypt. So is it better in the oncosurgeon's wide? I'm some sort, as an oncosurgeon, going to the oncosurgeon side? No, again, we meet very few early cases in Egypt. We don't believe, or many of them still don't believe of subspecialty. You work like a breast surgeon in the morning, a sarcoma surgeon in the afternoon, and a gynecologist in the evening. So you don't know what are the updates. So we have many, many combination of surgery with irradiation, which we all try to avoid. It's very common in Egypt to have a patient who had surgery and then had irradiation. And we do lots of salvage hysterectomy with no evidence of the value of that. And of course, the laparoscopy mania, you do laparoscopic hysterectomy, and we all know after LAC trials there is red flags about laparoscopic surgery in cervical cancer. So you do laparoscopy for advanced cases, and you have parametrial infiltration, and you have residue, and you have very recurrence. For the irradiation, it's not me who should talk about that, but I think we agree that we have long waiting list for the external beam radiotherapy machines, and we have very few brachytherapy machines. I was just speaking with Dr. Nirmin, Dr. Christine, Dr. Ghada about we have only 4 public machines, 1 in Alexandria, 2 in Cairo, and 1 in Manufaya, and we are now adopting 1 in Mansoura. And so giving the concomitant definitive chemoirradiation in time is not applicable in most of cases. You lost to give in the appropriate time, and then you can't go to have brachytherapy within the 5-week window after the external beam. So we shifted to neoadjuvant chemoirradiation followed by surgery with much, much inferior results. Really, we had to close in the interim analysis and we didn't complete after the pilot because it is much inferior results, or do the neoadjuvant irradiation followed by surgery, which is very morbid for the patients. And we have the problem of the cervical stump carcinoma, which is a unique Egyptian and Arabic problem due to the many, many subtotal hysterectomies which are done with no evidence or no science. So we have high rates of cervical stump carcinomas like that one. So the net result, that cervical cancer in Egypt, what we say always, it is not a surgical disease. We don't meet cases which are surgery. We know surgery in cervical cancer is up to stage 1B1. After that, you are going to refer for definitive chemoirradiation. And then you hear the surgeon saying, refer to neoadjuvant, and then we will do surgery. No, it is not neoadjuvant. It's definitive concomitant chemoirradiation with brachy. There is no role for surgery. So what happens if we meet an exceptional young cervical cancer patient? If you meet a 25 or 28 early cervical cancer, which is very exceptional. We don't meet that every day. What should we do? I'll do case presentations of 2 females from Egypt, 2 young females. The first, which I have presented in the Parsigo Virtual Women Cancer Day with IGCS. She was a 20-year-old lady, married for 1 year, didn't get pregnant. She had contact bleeding, and on examination, she has a 2-centimeter polyp that was removed. And the pathology was adenocarcinoma. It was so strange in a 20-year-old lady. This is common outside Egypt. The revision confirmed the pathology of adenocarcinoma, and the postoperative MRI, CT, TVS were free. This is the pathology. It was endocervical adenocarcinoma usual type, and the pathology was confirmed after revision endocervical adenocarcinoma. Here is the pathology of the girl. That was last November. And this is the MRI postoperative bulky size cervical canal normal study. And the pelvic MRI, no uterine or pelvic masses apart from anterior wall cervical cyst. That was in 11. And this is a TVS, again, that reveals that there is no residue. So we're speaking about a 1B1 case. The chest CT was free, the labs were normal. And then we proceeded for radical trachelectomy. I have really the privilege that I have seen, not trained. I have seen and assisted in many, many radical trachelectomies because I had my MD in National Cancer Center in Tokyo, in Japan, in 2012 till 2014. So I have assisted in many cases of trachelectomy for early cervical cancer there, but once I came to Egypt, I have never seen a case. So it was my first ever case to do as a trachelectomy in Egypt as the main operator. So we do the pelvic lymph node dissection and sent for frozen section. It was 3 lymph nodes, so we did the uterine artery ligation and this uterus after mobilization. And then we transected the uterus, the blood supply mainly on the ovarian vessels, and then we can do a trachelectomy like that. You can remove the cervix with a good safety margin. And the frozen section confirmed that the margins are free, upper, vaginal, and parametrial. And then we do circulage for the uterine isthmus for future pregnancies and the stenting. And then we re-anastomose the uterus again with the vagina. But the pathology reveals that there is a residue, which was grade 3 cervical adenocarcinoma, 2 centimeters, that wasn't in the TVS or the MRI. And there is no evidence of lymphovascular tumor emboli, free margins, free iliac lymph nodes. And so she was referred for chemotherapy. Again, we discussed it in the tumor board, and she was referred for chemotherapy, but there was some concern about the fertility, so she was referred for the fertility unit in Azhar University, and then she had some oocyte preservation. She finished her chemotherapy 3 months ago, and now we gave her a window of 4 to 5 months to get pregnant by the normal way and natural way. If not, we are going to use the preserved oocyte for IVF in case of any recurrence which happen. We are just following this case right now. And then in Cairo, I met this other young female. She was 28 years old, nulliparous, presented by vaginal bleeding. And then she had a TVS after she had a 6 cervix, low anterior wall, cervical mass 2 by 1 centimeter, no related infiltration, and the MRI confirmed that we have a 2 centimeter mass in the cervix. Again, this is the histopathology report after, of course, defloration. She had a defloration, legal defloration, and had a bunch biopsy, which showed a superficial material consistent with undifferentiated adenocarcinoma. Revision of the pathology was done and confirmed the same thing. And the TVS revealed that there is a lesion 2 by 1 centimeter. This girl, again, she met the problem that we are not well surgically trained for early cervical cancer. She's a virgin, she needs to preserve her fertility, and she, of course, from all the evidence, she has the right to preserve the fertility, but she went to a very big institute, and the big institute, they told her, you are going to do a radical hysterectomy. She said, I want to preserve the fertility, so they referred her for irradiation and chemoirradiation, which of course will destroy the fertility for her, and then she came to counsel me. Really, I told her that I have just done another case 3 or 4 months ago. She is doing okay. I can do the trachelectomy, but I told her, frankly, by the same words, I'm not the expert. If you are coming for me as an expert, you are my second case in Egypt. So if you find anyone in Egypt who have done a series larger than that, go directly for him, don't come back for me. I asked many of our colleagues in Ain Shams, in Asr al-Aini, in Asyut, in anywhere, if you have experience in trachelectomy, really I didn't find anyone, even in the big gynecology names, who performed that in Egypt. So I told her frankly that. And even she came to me in Oncology Center in Mansoura University. The director, Dr. Mohammed Higazi, asked me, does she know that she is your second case? I told her, I will not answer, she will answer you. She is very well educated. She came down and told him that Dr. Basil have told me that I'm his second case and I'm ready to have this. And then she had the same procedure like the first case, iliac lymphadenectomy, sent for frozen section, pre-lymph nodes, radical trachelectomy. We removed the cervix, the vagina, and the same procedure like this one. This is a lesion, and this after anastomosis. The paraffin result was well-differentiated endocervical adenocarcinoma gastric type. And again, it was the first time for me to hear about gastric type adenocarcinoma in cervical cancer, pattern B stromal invasion. By the way, again, the one who told us to see the SELVA pattern of invasion, if A or BC, was Pedro Ramirez from MD Anderson in the first case. He taught me to do that, so I returned it back to my pathologist and I asked for the pattern of stromal invasion. The depth of stromal invasion was 4 millimeter, no lymphovascular emboli, and the distal septic margin was free. It was FIGO stage 1B1. This is the report. So what is the IGS ECO project? This is a project that we adopted with the Parsigo and the ECO, where we do a monthly 2 tumor boards, 2 Zoom virtual tumor boards with experts from the International Gynae Cancer Society and the European Society of Gynae-Oncology. We have here Robert Coleman, who is the head of IGCS and the head of oncology force in the USA. We have Pedro Ramirez from MD Anderson. We have Jalid Suhouli from Charité Berlin. We have Sarah Nassar from Charité Berlin. And we have pathologists from Gemelli from Rome. So we deal every month, we prepare all our difficult cases and we present in the ECO tumor boards. That's for free. There is no fees at all. This is just a project for the developing countries. And we discuss the cases. I believe Khaled Abaziz is here in one in the photos. Khaled was joining us in many, and Dr. Namet, of course, was us from Alexandria. And they said this gastric type pattern is very aggressive, and this patient wasn't candidate for trachelectomy. And if we know that this is gastric type, we rather go for hysterectomy and do a PET scan to see if there is any mets, and get it back for hysterectomy or have chemoradiotherapy. But after adding the P16 and the revision of the pathology. So we did revision of the pathology with Dr. Elia, and we did it was positive for P16, and the final that is cervical adenocarcinoma, the usual HPV type. It is not gastric type. We return it back to our pathologist in Mansoura, and they confirm it is the usual type, and we return it back to the project and say, so we can go just for observation. This is stage 1B1, usual HPV type, and this is a PET scan after 3 months. It is free. She has no recurrence or metastasis. We are following here right now. So what we are doing to try to solve the problems of cervical cancer in Egypt, we start to raise the awareness about the disease like what we are doing right now. We are starting to raise awareness about the vaccine. We have no platform to do. We do it on social media. And really, I had the honor that I vaccinated right now in Mansoura and Cairo more than 250 cases. That was 3 months ago, 250 cases vaccinated by the Gardasil, which is a tetravalent. I really suffered so much to find the vaccine and bring all the numbers from MSD. And then we vaccinated them. I vaccinated my girls, I vaccinated all my family, and they all have the vaccination against HPV. And what happens that even the vaccine companies are saying what's happening in Mansoura. The pharmacists are calling, where is the vaccine? We want the vaccine. Many people and many ladies are calling the pharmacists in Mansoura asking about the HPV vaccine, which I more or less I consider a success in raising awareness in Mansoura and try to go this all over Egypt. And then for long term, we have been establishing the Egyptian Gynecology Society. It was launched by paperwork last September, and the first meeting for Egyptian Gynecology Society will be held with the fifth go in 11th and 12th of November. Dr. Saeed Abdelhadi is the head of the Egyptian Gynecology Society, and Dr. Ahmed Sektouri is the vice president of the society, and I'm the general secretary of the society. We are having all the collaboration with the IGCS. Robert Coleman will be with us. Pedro Ramirez will be with us. And we have the whole support of ESGO. It is an ESGO-endorsed meeting. And Philip Maurice is with us. And Nicole Consin, the president-elect, who is with us here. But we have the problem of training, how to go for training. Mansoura is saying we are good. Ain Shams is saying I am good. And Cairo National Cancer Center said I am the best. So we don't have registry, we don't have number, what to do. So we went for accreditation. We have been working for years with the ESGO to have a certificate of accreditation that the Surgical Oncology Unit in Oncology Center Mansoura University is the first center outside Europe rather than Israel. It's the first center outside Europe, the first center in Egypt, the first center in Africa and Middle East to be recognized as accredited European training center in gynecology, and this certificate is valid for 2 years, and then it can be retracted if we are not up to the standards. So this was a very big achievement. Just we have this certificate in September 21. It was less than 1 week ago, and we did much celebration in Mansoura for that. And then we go for launching of EGOS. We invite you all to be with us to unite forces for that in the 11th and 12th of November. And we received the email yesterday that it will be at ESGO endorsed meeting to try to do something in the field of gynecology in Egypt. And thank you.
Thank you, Dr. Basil, for this nice presentation and for these 2 challenging cases. And congratulations for the accreditation. Is there any questions for Dr. Basil?
I just want to ask a question about Gardasil. What's your recommendation, the age of vaccination? Because in Europe they start at 9, I think. Yes, Gardasil, I start vaccination starting from 9 years old. The best ever start to have the vaccine before sexual practice. So they say in Europe it is in 11 to 12 years old. It has been implemented in the vaccination programs in USA, in Canada, even in Saudi Arabia. It has been implemented in some places in the vaccination program for girls. So we don't here go for 11 to 12, I can say up to marriage or up to the sexual practice, but the best results are before the first sexual practice. What I usually say, even for my daughters, yes, we are an Islamic country. Yes, we are a conservative country. Yes, we don't have many sexual partners. However, everything is changing. We have some data about HPV infection outside of sexual context, from just the toilets, from the gymnasium, from the contact. And again, if you are so sure of your girls, you are not sure of her husband. We have many of husbands who are abroad in Egypt, working in Gulf and working in Europe. You don't know, you are not guaranteeing. So why not have we do 2 doses before 15 years old. There are 2 doses, 0 and 2. And after 15 years old, we give 3 doses, 0, 2, and 4 months. It is affordable, I think. It's not expensive. It is affordable for many people in Egypt. And what we are doing right now from EGOS, we try to do registry to make it like implemented in the vaccination programs in the girls in the school. I hope we will do that in the next decade. Thank you so much. Thank you.
Now we'll move for Professor Ahmed. We'll talk about metastatic ovarian cancer, art of drug choice.
Good evening, everyone. The disclosure or the aim of my lecture today is going to how to use our tools to treat ovarian cancer, especially the recurrent one, with our clinical practice and the clinical guidelines in combination. Risk factors for ovarian cancer may many different factors may increase the person's risk of developing ovarian cancer: being older, using hormone treatment after menopause, having overweight or obesity, giving birth late after 35 years, or never having full-term pregnancy, undergoing IVF, having familial history of ovarian or breast cancer or colorectal cancer, and having more menstrual cycle throughout one's life. In recurrent ovarian cancer, there is an important prognostic factor at the time from the end of the previous treatment. It's called treatment-free interval. Time to relapse is used as a determinant factor for tumor sensitivity to platinum compounds. The platinum refractory, resistance, and sensitive, either partially or highly sensitive. And it is a time lapse between when to stop and when the tumor recurs, the 6 months and 12 months. The problem is to have a second surgery after the relapse, after a first surgery. The German group first do an AGO desktop OVAR trial. The first one, they showed 3 factors being independently associated with complete resection. These factors are the macroscopically complete resection after the first surgery, the good performance status, and absence of ascites, or not more than 5 milliliters. These factors were combined to be the AGO score that deemed positive if all 3 criteria were fulfilled. Then they stated that the survival analysis showed the median overall survival for around 45 months in completely debulked patient as compared to 20 months almost in patient with incomplete resection. And these data were verified in the second trial, the same group, and the rate of complete resection, the second resection, was almost 76%. Although negative score might not exclude the possibility to achieve complete resection by the surgeon's words. The third trial for the AGO group, they evaluated the second-line chemotherapy alone versus the cytoreductive surgery for the same chemotherapy platinum combination, as they recruited patients of metastatic or recurrent ovarian cancer and their first relapse after 6 months of platinum-free interval. And the analysis according to the treatment showed that the overall survival benefit exceeds 12 months for the patient with complete resection compared to patient without surgery. The median was 60 months versus 46 months, while the patient with surgery and the incomplete resection did worse and they did reach 30 months. What about the other patients? The platinum resistance, the patient with comorbidities, and we deal with them every now and then. The older patients with comorbidities like the cardiovascular disease or CNS disease, obese patient with high risk of DVT, especially after major pelvic surgeries, plus the pelvic recurrence if happened. The ascites, either malignant or nutritional, or due to liver insult from previous chemotherapy protocols. Renal insufficiency, either iatrogenic due to our treatment or age-related. There is the CCI index. It predicts the 10-year survival in patients with multiple comorbidities, and we have the same, and we have the classic patient to put it in this scale. And this scale, we can put the age and the multiple comorbidities if present, either myocardial infarction, chronic heart disease, peripheral vascular disease, dementia, COPD, cardiovascular disease, diabetes, hypertension, peptic ulcer disease, connective tissue disease, and other factors. You have to fulfill it in this, and you will have a percentage. The common comorbidities prevalent in ovarian cancer patient were the hypertension from 10 to 26%, cardiovascular disease 5 to 12%, diabetes 2.5% to 8%. And less commonly occurring comorbidities were liver, renal, and neurological problems, and collagen vascular disease. And the majority of ovarian cancer patients lie in score 0, around 70 to 75%. And the range for 1 year survival, according to this score 0, almost 8%, score 1 to 2, almost 70%, score 2, almost 50%, while if we go for the 5-year survivor, this score will drop to, the survival will drop to 40% for score 0, 30% for score 1 to 2, and 23% for score 2. Treatment lines for relapsed ovarian cancer, we have many treatment lines. We listen one of them, the olaparib or the PARP inhibitors, but we have a lot of lines like hyperthermic intraperitoneal chemotherapy, angiogenesis factor, VGFF, either a VGF like bevacizumab or VGF inhibitors for receptors like the pazopanib and its family, angiopoietin inhibitors, PARP inhibitors, tyrosine kinase inhibitors, folate receptor and alpha inhibitors, and immunotherapy, immune checkpoint modulators, adoptive T cell transfer, and the last one, and we see it a lot in our practice, how to palliate or do treatment as a palliative measure for malignant ascites for these patients. The HIPIC is a combination of cytoreductive surgery and hyperthermic intraperitoneal chemotherapy used in combination with systemic therapy. Start either about 3 weeks after surgery, or with patient with late recurrences after several lines of chemotherapy, or patient with a large residual disease after primary surgery, or those who have an operable lesion. Usually we use cisplatin, maybe doxorubicin and taxanes. But a major complication are happening with this technique, especially anastomotic leakage, bowel perforation, intraperitoneal hemorrhage, and wound adhesions. Reported comorbidities or morbidity with this line of treatment may reach to 30% of grade 3 and 4 grade morbidity, according to Cleveland-Dido classification, and mortality rates may reach to 4%, and some authors may argue that these complications may be observed only in cytoreductive surgery alone. Angiogenesis inhibitors increased vasoendothelial growth factor expression has a prognostic value in relation to the tumor grade, stage, and patient survival. These receptors are present on the surface of the ovarian cancer cells and seems to play a role in development of malignancy by increasing the vascular permeability in the peritoneum, and it is responsible for formation of the acidic fluid in ovarian cancer. Consequently, inhibition of these receptors may be a good option for treatment. Three phase 3 trials in recurrent ovarian cancers investigated a total of 1,500 patients, were included into 2 meta-analyses, and both meta-analyses showed that adding the beva to the standard chemotherapy improved the overall response rate, progression-free survival, and overall survival, but with higher toxicity, grade 3 or grade 4. And here is a correlation between the beva and the hypertension, that there is for vasoendothelial growth factor A, B, C, and D. A binds to the receptor 1 and 2 through the mediated angiogenesis through these receptors, especially receptor 2, while the VGFR receptor functions, one receptor functions primarily as a decoy receptor for the VGFA. While the neuropilin co-receptor NRP1 and NRP2 regulate the receptor signaling and binds to the vasoendothelial growth factor by beva and prevents the VGFA activated receptor signaling. Here is a diagram showing the 5 receptors. Receptor 1, VGFR 1, 2, and 3, and NRP1 and 2. They are partially blocked with the action of bevacizumab, while the rest of the receptors is not affected. Possible pathophysiological mechanisms of bevacizumab-induced hypertension: vascular endothelial growth factor blockade by bevacizumab and decrease the vascular endothelial growth factor receptor 2 signaling contributes to systemic vasoconstriction and increase the peripheral vascular resistance as a result of endothelial dysfunction and vascular abnormalities. And it may also alter the renal structural function, leading to inadequate renal sodium excretion and volume overload. These two mechanisms are the only supported by evidence. While there is many evidence, many mechanisms remain still controversial, especially the genetic factor and the age group, and the risk of severity and the environmental may influence the risk of severity of bevacizumab. And here is the vasoendothelial growth factor blockade may lead to decreased nitric oxide, decrease in postacyclin, increase in endocyclin 1, oxidative stress, microvascular rarefaction, and vascular stiffness, may lead to systemic vasoconstriction, peripheral vascular resistance. While it may affect also the kidney, may cause renal injury, abnormal pressure natriuresis, and activated renal angiotensin system. It may lead to decrease the renal blood flow and altered sodium homeostasis, may lead to volume overload. These two factors may lead to hypertension, and this is the mechanism of the hypertension with the beva. In conclusion, beva has been shown improvement of progression-free survival for 2 to 4 months in some setting, and also overall survival, although it's associated with higher degree of side effects. The price reduction will be required for the product to become cost-effective for the majority of national health services. So far, there is no predictive biomarker that found or could help to select a patient who could be greater benefit from beva. Another one, inhibitors of vasoendothelial growth factor receptor, is called sidranib. In the ICON 6 trial, addition of sidranib yielded improvement of progression-free survival of 11 months observed in the group, and still the toxic effect was the most common cause of discontinuation, and the most frequent were diarrhea, neutropenia, hypertension, and voice changes. The badobanib in AGOVAR 16 phase 3 trial, it have a better progression-free survival in patients receiving bazobanib. Median progression-free survival reached almost 18 months than placebo. The first interim analysis of overall survival didn't suggest any benefit. Grade 3 or 4 adverse effect of hypertension 30%, neutropenia 10%, liver-related toxicity 10%. But bazobanib shows advantage toward longer progression-free survival, both in treatment in platinum-resistant and refractory ovarian cancer, and in platinum-sensitive maintenance. The PARP inhibitors, and we listen a lot about the PARP inhibitors in the previous lecture. The olaparib and niraparib have recently become standard of care for patients with recurrent BRCA-mutated ovarian cancer. In addition, it was shown olaparib significantly improves the progression-free survival in patients with platinum-sensitive recurrent ovarian cancer, regardless to the BRCA mutation. And the niraparib also shows improvement of progression-free survival in the same setting, regardless to the BRCA mutation and HRD status. Despite of that, BRCA1 and 2 mutation and cisplatin sensitivity are accepted predictors as response for PARP inhibitors. Thus, now it's widely accepted that BRCA testing should be offered for all women with ovarian cancer. And I'll skip this as a slide. And here, the main slides, palliative treatment for malignant ascites, mechanisms leading to develop of ascites associated with intraperitoneal spread, plus the lymphatic obstruction, increase the vascular permeability mediated by vasoendothelial growth factors and interleukin 6 and 8. Repeated paracentesis provide temporary relief of symptoms, but associated with several side effects, including a loss of protein, hypovolemia, and circulatory problems, and risk of bowel perforation. The various immunotherapeutic modulators currently tested for management of peritoneal metastases and ascites, including T cells, checkpoint inhibitors, antibodies, vaccines, dendritic cells, and various virus-based. There is 2 drugs. One of them is catumaxumab. This drug was injected for 1 patient, and he died from the first shot. And this study with this drug was closed from the first patient. The aflibercept 2 randomized double-blinded placebo-controlled phase 2 trials was diagnosed to investigate the safety and efficacy of IV aflibercept in inhibition of ascites formation in patients with advanced chemo-resistant ovarian cancer. Time to next paracentesis was significantly longer in the experimental group in both studies, 55 days compared to 23 days in the first one, and 76 days compared to 16 days in the other trial. The take-home message: ovarian cancer is not a sole disease. Most of the patients have multiple comorbidities either before starting treatment or newly developed through the course of the disease. Put in consideration the treatment cost, progression-free survival, overall survival, addition to the probability to that effect which may develop during treatment. Have to know the mechanism of action of drug you have to choose for the patient to get the proper clinical benefit with the least side effect, which by the way mostly are inevitable. Thank you.
Thank you, Dr. Ahmed. Any question? Yes.
انت بتضحك اهو عارف طيب هو بس انا ليا تو كومنتس يا احمد على الحاجه الاولانيه. انت سالتني قبل المحاضره why you are as surgeons reluctant in doing secondary cytoreductive surgery in ovarian cancer. قلت لك احنا we are never reluctant for that، بس في كلمه بقولها قبل ما ابدا الكلام خالص مع البيشنت بتاعي: recurrent ovarian cancer is incurable disease. there is no hope for cure. والكلمه دي لازم تبقى واضحه وصريحه حتى لو مش قدام البيشنت نفسها، قدام الفاميلي او الناس الكير جيفرز بتوعها. احنا بنتكلم ناو لو كنا بنتكلم في ستيج 3 4 اوفرين كانسر عن ريلابس ريت 70 80%، فبنتكلم ناو ريلابس ريت 100%. وبالتالي ناس كتير بعد ما تسمع الكلمه دي حتى لما تقال بمنتهى الذوق كده زي ولا سكيب سيرجري. دي اول حاجه. تاني حاجه الخطوات اللي انت عرضت الديسكتوب ترايل اللي قالت ان في يعني سرفايفل بنفيت، اتس بروجريشن فري، اتس نوت ان اوفر اول سرفايفل، بروجريشن فري سرفايفل ويز نو كيور للديسكتوب كرايتيريا اللي هي بلاتينم سنسيتيف تيومر ومفيش اسايتس والتيومر ماركر. وفي نقطه مهمه ان الجراحه الاولانيه معموله اوبتيمال. دي نقطه مهمه جدا في الديسكتوب ترايل. طيب الجي او جي 213 اللي عملها روبرت كولمان قال مفيش خالص رول للجراحه خالص، ودي بقت هي على طول بيتقالوا قصاد بعض ان مفيش رول للجراحه في السكندري في الريكارنت اوفرين كانسر. وفي نفس الوقت ما قالش النقطه بتاعت احنا عندنا معظم الحالات اللي اتعملت الاول مش عامله كومبليت سيرجيكال ستيجنج، ما عملتش اومنتكتومي، سايبه اوفري، يعني الاوبتيمال سيرجري في الاول دي قليل جدا بنقابلها. فانا بقابل حاليا غالبا حتى لو العيانه فولفيلنج الاي جي او كرايتيريا الجراحه الاولانيه مش معموله صح. فلازم بقول لهم الكلمه بمنتهى الوضوح: احنا داخلين trying to achieve some sort من هامش البروجريشن فري سرفايفل، بس احنا this is incurable disease. وده مهم جدا في حالات الريكارنت اوفرين كانسر عشان النقطه الثانيه دي
it will prolong the overall survival. احنا كل بنتكلم على البروجريشن فري
but no cure, there is no cure. مفيش حاله الريكارنت اوفرين كانسر and she will be cured يعني. النقطة الثانية الأهم في دي بقى عشان الهايبك مينلي، وأنت عارف أنا لسه مختلفين بره. I totally disagree إن عندنا دلوقتي evidence level 1 or even 2 على الرول اوف هايبك in recurrent ovarian cancer. الرول اوف هايبك حتى الآن evidence بس في الانترفال debulking not in primary and not in recurrent. ويمكن في القاهره لما زي ما قلت لك بدات شغل كتير، كان كل شغلي لا نو رول فور هايبك، نو رول فور هايبك. حالات كتير جدا جدا بيتعمل لها هايبك اي اجري، بس يتعمل ان ذا فورم اوف كلينيكال ترايل والعيانه تبقى فاهمه ان ده سامثينج انفستيجيشنال وما عنديش ايفيدنس عليه، يو ماي بينفيت فروم ذات، ومن اللي انا شايفه زي نيفر بينفيت فروم ات. فاي توتالي ديس اجري ان انا احط الهايبك كواحد واتكلم عليه اول حاجه في اللاينز اوف تريتمنت.
still it has its own morbidities more than the surgeries.
very high morbidity. حتى لو مش حتى انا بتكلم الناس احنا نوعا ما، وانا بتكلم يعني ما عنديش كونفليكت انترست ان انا اللي ادوبتنج الهايبر بروجرام في المنصوره، انا اللي جبت الجهاز وانا اول واحد اشتغلت عليه، بس بشتغل مني في سيدوماكسون بروتونياي واشتغلت في كوريكتال كانسر لحد ما العالم كله اثبت ان مفيش رول في كوريكتال كانسر، فوقفت الكوريكتال كانسر. وبعدين الاوفري وقفنا في الريكارنت، بنشتغل في الانترفال ديبالكينج وفي كلام دلوقتي على البرايمري سيتنج بس ستيل انفستيجيشنال. فالعين يبقى عارف انما هو مش لاين اوف تريتمنت، لانه بيبقى اوفرد، وبالذات بلوف في القاهره اوفرد كتير جدا جدا اي حاله ريكارنت اوفرين كانسر ايكوالز هايبك، وده كلام بصراحه ما انزل الله به من سلطان يعني. فاي ديس اجري كالهايبك كلاين اوف تريتمنت. والجراحه ان العيانه لازم قبلها تبقى عارفه ان ده انكيورابل وان ده ممكن يديني سرفايفل، والسرفايفل ده غالبا بالسكند لاينز بالبيفا وبالاذر لاينز ممكن تاخد نفس السرفايفل بنفيت دي من غير الجراحه مره ثانيه. ثانك يو.
Thank you. Any other suggestions?
Dr. Ahmed, thank you for this elegant presentation. In your opinion, which patient should receive Avastin in the first line? Do you give it only to the high-risk stage 3 who did suboptimal debulking at stage 4, or you give it whatever advanced stage 3 or 4?
In my practice, I give the bevacizumab mostly for the recurrent disease in the peritoneum, mainly. If the metastasis in the lung or in the bone or in the liver, I may reconsider other lines of treatment. But I encourage using the beva in the peritoneal deposits mainly because of its potential action in this part. But in the stage 3 and 4 recurrence.
No, I'm talking about first line.
No.
First time.
Not. I didn't give him. I will strive the platinum-based protocols only. Carboplatin-based chemotherapy.
So you don't give beva in the first line, even if the patient have high risk stage 3 suboptimal debulking or stage 4. You don't give it.
If the patient has a suboptimal debulking, I may go first for the platinum compound to check the sensitivity. Then, if the response is not optimum, I can add beva.
Dr. Ihab.
هو دلوقتي بالنسبه للبارب انهبيتورز في الكانسر اوفري، اللي انا فاهمه ان احنا اتثبت ان احنا نعمل على التيشو نفسه في الاول خالص، ان احنا نعمل نشوف البارب في بارب ميوتيشن ولا لا، وبعدين ولو ما فيش بنعمل ليكو بايوبسي، وبعد كده ممكن نحتاج لو طلعت نيجاتيف هحتاج ان انا اعمل برضه تيشو تاني عشان اتاكد ان في سوماتيك ميوتيشن ولا لا.
انت قصدك حضرتك على البريكا ميوتيشن؟
بريكا ميوتيشن اسف.
احنا بنعمل كده لما البيشنتس بيحصل لهم ريلابس ونشوف ان هم غالبا بيبقوا بلاتينم سنسيتيف، بنشوف البارب.
لا انا بتكلم عن اب فرونت، يعني اب فرونت ان هو دلوقتي اوليبريب بيستخدم في الناس اللي هو كمينتنس، فاب فرونت انت بتعمل على التيشو الاول على البراكا
تيشو اند بلود.
نعم
تيشو اند بلود.
يعني تعمل ليكو بيوبسي وبتعمل عشان تشوف الجيرم لاين وتشوف السوماتيك ميوتيشن.
مظبوط.
تمام كده. طيب بالنسبه لحضرتك قلت في الريكارنت ان هو لو العيان كان بلاتينم سنسيتيف ريجاردلس البراكا ميوتيشن ممكن تدي اولوباريب.
ده في الريلابس ديزيز. هو كده بيبقى فيه
ريسبونس. ايه الاستادي اللي انت بتعتمد عليه في الكلام ده؟
الاستاديز اعتقد ان هي موجوده في السلايدز،
اللي هي حته ان انت لما في البلاتينم سيستيف
هو كده
ريجاردلس البراكا ميوتيشن
both have the response in the.
هو الشركه بتقول كده بس انا مش عارف، الشركه بتقول كده بس انا مش عارف.
لا مش
هو معتمدين على ايه في ايه الايفيدنس بيس بتاعك عشان تعمل كده؟
البيبرز اهي حضرتك. اعتقد ان هي كان اسمها مش فاكر البيبر اسمها ايه اهي.
البراكا بتدي بس انا مش عارف موجود كام بس ايه.
اعتقد ان هي this paper اللي هي study 19 AG 19 tried efficacy and safety compared to placebo platinum sensitive relapsed high grade serous ovarian cancer patient showed olaparib maintenance significantly prolonged progression regardless to BRCA mutation. يعني هشوف حضرتك البيبرز دي انا اللي محضر منها، بس اعتقد ان هو كده ان البريكا ميوتيشن سواء لو موجود لو ما فيش بريكا ميوتيشن في بلاتينم سنسيتيفيتي، سواء الميوتيشن موجود او مش موجود في الديزيز ريلابس، بندي الاولاباريب ريجاردلس للسنسيتيفيتي ريجاردلس للميوتيشن. انما احنا بيبقى الريسبونس احسن مع السنسيتيفيتي تو بلاتينم كومباوند والنون ميوتيتد بريكا جينز.
So by this we come to the end of the session. Thank you for the speakers, thank you for the audience, and thank you for the organizing committee.